Good evening, everyone. Welcome to First Aid AMC Clinical. I am Dr. Arshan Ahmed, and I'll be your mentor for the next 5 months AMC Clinical course. Now, many of you know about First Aid AMC, how our course usually performs every month. You know that our course has the highest number of passing candidates in both AMC, MCQ, and Clinical. If you are a member of our First Aid AMC Clinical Facebook group, you are aware that like every month from our course, there is a huge number of candidates who are passing. You know that AMC clinical exam is not a very easy exam to pass, and it is one of the hardest exam you will ever appear. It's just like any of the final exam of any specialist degree. So this is going to be hard, but it's not like that it's impossible. And if you look into our course, if you see our post and everything, you can easily see that every month there is a lot of candidates who is passing. So there is nothing like you can't pass this exam. And most of our candidates who pass this exam, they are first time attempt. So first time candidate passing AMC clinical, it's a dream. But through our First Aid AMC clinical group, we have seen that most of our students who are passing, they are first time attendees. So it's not impossible anymore. If you know what to read, if you know the guideline well, if you know how to do a proper role play, if you know what to prepare for, it is not the hardest exam to pass. But I have seen a lot of candidates who waste their time a lot by searching different notes, different course, and lots of other things. But I suggest that if you want to pass this exam, you have to be very smart. In your head, you can't just waste your time by looking for a lot of things. Our course will provide each and everything that you need. You don't need anything else. So if you just focus on the materials that we are going to provide, if you can focus on the classes that we are going to take, that will be enough to pass this exam. But we can't guarantee that you will pass the exam unless you do your part, because you will have to do your hard work. You have to do role play of all the cases that we are covering in your class. So if you don't do that, then yes, you can't pass this exam. And remember one thing, a lot of you are specialists. A lot of you are doing lots of specialist degrees in your country. But that doesn't necessarily mean that you will just pass this exam without any difficulty or without any preparation. This exam has its own format. It has its own level of difficulty. So without understanding how this exam works, how examiners passing the candidates, if you don't know that, it is hard. But with appropriate course materials, with appropriate guidelines, books, and everything, you can easily prepare for this exam. So we are going to give you some idea how First Aid AMC Clinical takes their classes. So today it's our psychiatry review session, and we will mainly focus on a very important topic that comes in your exam, which is mental status examination. Psychiatry is hard in exam. This is one of the hardest topic because the role player will give you a hard time. And because they are psychotic patients, some are depressed patients, it is hard to take history from these patients rather than a normal patient. So psychiatry is an important thing to grab to at least understand how your approach should be in this exam. Before we start our psychiatry class, I'm going to give you a baseline idea that how this exam works and how to start your preparation. And also, we will discuss about the upcoming course that is starting from 10th of March. So today is 25th of February, so you still have 2 more weeks before we start our full course. On 10th of March, we will start our free 2-week session. And with the free 2-week session, you'll get some idea that how our theory classes work, how our the role play sessions work. All right. So it will give you an idea of all the classes that we are going to take in your course. And Today, if you have any questions about how the course is going to work, how the exam is going to happen, you can always ask me at the end of this class. If you have any questions about the materials and about the topics that we are discussing today, you can write it on the chat box for those of you who are in Zoom. And many of you are in Facebook live session. You can also just write something on your comment section. I will have a look. Now, before we go into our psychiatry session, let me give you just a baseline idea about AMC clinical exam. AMC clinical exam is kind of a OSCE exam. So many of you who, like all of you obviously passed your MBBS. So in your final medical examination, you had to go for long case, short case, some of those OSCE exams, all of you has done already. So AMC clinical exam is something like that. In AMC clinical exam, because this year it's going to be online exam, so none of you are going for face-to-face exam as far as we know so far. Online exam, it is easier in that way that you don't need to come to Australia to appear the exam. You don't need to worry about your visa anymore. So that takes a lot of time, a lot of issues with the visa and everything. So that's one of the positive point. You can appear the exam from your home. But the difficult part is to pass this online exam, you need to be a little bit more fluent in your English, because it's all about discussing, it's all about talking and everything. But you don't need to have a English accent, like you don't need to have an Australian or British accent to pass this exam. Your accent is fine as long as we can understand you. As long as the role player who is giving the information, he or she understands your accent, you are fine. So if someone think that no, my accent is not good, it doesn't sound like Australians, it's fine. Okay? So there is no problem with that. I've seen a lot of people whose accent is not good at all, but still they pass the exam in their first attempt. So it's not what they look for. They look for if they can understand your question and if you can understand them. So that's all that they need to pass your exam. Now, the difference between online and face-to-face is that in face-to-face, the physical examination cages, you have to do physical exam on that patient and you have to find the findings from that patient. That's a bit difficult because you are given a very small amount of time, and in the time period, they will ask to do a physical exam on a simulated patient, find out the important findings through your examination, and then give the diagnosis. So that was a bit difficult in face-to-face, which is better in online exam because you don't need to do any physical exam on a patient. You are just discussing to an examiner or to a medical student that this is how you are going to do a physical exam. So you're just discussing. So that's why fluency is important because you will be discussing a lot in online exam. So in our course, we are going to focus mainly on online exam, no more face-to-face for this year. So our main focus will be online. So in online exam, once you start our course, usually in the initial few classes, we will give you a orientation session on online exam itself. So someone who has recently passed their exam through online exam, we usually ask one of our candidate who just passed to give you a brief, a detailed idea about the online exam. So that we give for every course students, we provide these kind of classes so that you know what kind of online exam you are going for. So I'm not going into too much detail today for that reason. And there will be a separate orientation class after the first 2-week sessions where we are going to discuss each and everything about clinical exam again and how our course works, how you should prepare, everything. But tonight we are going to give you just a simple idea what's clinical exam. So online clinical exam, there will be you on the screen, there will be an examiner, there will be a simulated role player, and then there will be an invigilator. You will rotate in 16 rooms. So exams are taken in Zoom as well. So you'll join their Zoom session. And once you join the Zoom session, first of all, you will be talking to an invigilator. The invigilator will give you a detailed idea about how this online exam is going to work. After that, you will be moving to 16 stations. Each of the stations, you will have a role player who you can see and talk, an invigilator who is not a medical person and who doesn't give any answer related to your exam. The invigilator is only supposed to rotate you in different rooms and just some of the logistics involved with your exam. So they are not the medical person most of the time, and they usually don't give you any kind of information for the cases that's coming in the exam. And then there will be an examiner who is going to mark you. You can't see the examiner, nor you can talk to the examiner. So examiner will be completely muted throughout your exam. And you can't also ask any exam-related questions from an examiner. Okay? So this is one of the stations, how it will look like. In one station, you will be given a case. So they will give you a station, and what the cases will be, like we will discuss some cases today so that you get some idea. So they give you a case like a patient coming to you with low mood, sleeping difficulty, and then they're going to give you some task. The task can be take history from the patient. Then the second task can be physical examination card will be given on the screen. So sometimes they give physical examination card. Third will be give your diagnosis and differential diagnosis, and then management. So this is a usual task. History, physical examination given on the card, and then give diagnosis and differential based on the history and physical exam, and then talk about the management. You will be given 2 minutes initially to read this case and think about this case. So you'll get 2 minutes where you will be reading this case and think about what you are going to ask to the patient. Once 2 minutes is over, the invigilator will ask you to start the case. And you'll be given another 8 minutes to finish all these tasks. Okay? Task can vary. It's not always history, physical exam, diagnosis, and management. It can vary. So you will only do your task as it is given in the exam. So you can understand each of the stations give you 10 minutes. Right? And after 10 minutes is over, your exam will be finished and you will move to the next station. In this way, you will be moving to 16 stations. In between every 4 stations, there will be a rest station, which is also 10 minutes, where you can take rest, you can eat or drink if you want. Now, there's a lot to discuss about how online exam actually works, which I'm not going to do today, which our course students, you will get a detailed class just on online exam logistics, like what you should do, what kind of screen you should have, what should be the, like, should you, like, can you have a Bluetooth speaker or not? So all those logistics we are going to discuss in our separate online exam class. Okay, but AMC, if you go to the AMC website, they have written each and everything. like what you can take in the exam, what you should and what you shouldn't do in an online exam. Everything is written very clearly, but still, we will discuss that in our separate class. Okay? Now, as you can see, there are 16 stations. Out of these 16 stations, 2 stations are pilot stations. That means these are not scored stations. To pass your clinical exam, you will be only scored against 14 stations. So these 2 stations are not scored. And you would not know which one is pilot and which one is a scored station. So every station is equally important for you. Out of this 14 station, if you pass 10 station, you pass this exam. Okay? There is no, so you either pass or you fail. So if you don't pass 10 station, you will need to reappear the exam. Okay? So that's like a very concise way of saying how AMC clinical exam going to work. Do you guys have any specific questions so far that you want to ask? If not, then we are going to start our psychiatry class. There is no more any retake. So you can't do any retake anymore. So you either pass or fail. So retake is abolished. Any question, guys? What does a brief history entail? Brief history actually means that just a very focused history. And the focused history, it means that you don't take it, like you don't take 6 minutes for that history. So just the important things for a particular case. Okay? We will discuss this kind of cases later on. Can we ask for physical examination or investigation to the examiner? So you can't ask for anything more. So if there is a physical examination card given, the card is supposed to give every information that you need. So you can't ask for any more than what's given, and you can't ask any investigation to the examiner unless it is a task. Sometimes there is a task that ask investigation from examiner. If there is a task, then yes, you can ask, but otherwise you can't. No, Dr. Sharat. So it means that there is no restriction of how many times you can appear clinical exam. You can appear as many times as you want. So there is no restriction on that. Yes, you can't even ask the hemodynamic stability from the examiner because examiner doesn't talk in the exam. How candidate know the diagnosis? Because they will give you a history. So you will be able to take history from the role player and the physical examination finding will be given. So on the screen, you will get a card where all the physical examination findings will be given. So you can easily diagnose based on history and physical exam. So retake is, I don't think we need to discuss about retake anymore because it has been abolished for years now. So previously there was a thing like if you don't pass like 10 stations, so if you pass let's say 8 or 9 stations, in that case sometimes you could just give a you could just reappear the exam and you didn't need to appear 16 stations. You could just appear small number of stations and they would pass you if you pass those stations, which is no longer needed to know because it's no longer here. So let's not go into that direction because it's totally abolished and it will never come back. Should we wait if we finish before 10 minutes? Yes, most likely you should wait. And if you want to finish, you can always tell your invigilator that, yes, I want to finish now. Then they will just send you to a resting room. And in case of, I don't know, Dr. I, so you don't need to write multiple times. I can see your questions. So in pneumothorax or pulmonary embolism, those physical examination cages, they provide a X-ray. So if you have the physical examination and you see the X-ray, you can easily diagnose those cases. So they are not going to give you anything in the exam which is ambiguous or which no one can diagnose. So they are usually very relevant. If they're asking for a diagnosis, they will provide enough information to you so that you can diagnose that case. If you pass 9 station, you have to go for a whole exam. That's right. And why I think the passing rate is low? It's all about preparation, because most of the candidates, they don't know how to prepare for the exam. They don't know the proper approach, how to talk to a patient in Australia. They still think that this is their country they're working in, or this is their country's exam. This is the Australian exam, and the examiners are most of the time they are Australians as well. So you'll need to fulfill those criteria so that you know the guidelines here, you know how to approach a patient properly in here, and you know how to talk. So most of the candidates who fail this exam is because they don't know how to approach a case. They don't have any format in their head, and they don't have any particular kind of preparation. So that's basically it. If you know the cases, how to approach those cases, there is no way anyone should fail. But most of the candidate we see is that because either they are very overconfident that they don't even prepare for exam properly and they just go for the exam, thinking that they are a specialist in their country and they can pass any kind of exam, or some are just they don't prepare. They are not a specialist in their country. Maybe they're intern in their country, but still they feel that they can go for the exam without preparation. Or some people I see that they go for some of the courses which actually their mentors are not even working in Australia, or they are not even like they are not even from Australia. So how can they prepare for this exam if they're not working in here? So those are some of the shortcomings we have seen time to time that why they don't pass the exam. Okay, but communication is important. It's not about accent, I always say. It's about how you approach, how gentle and caring you are as a doctor. That makes a lot of difference. Okay, now let's move on to our class. And after that, at the end, we will discuss a little bit more about how the markings work in exam, like how usually they mark you. And also we will discuss a little bit about the course. Okay, let's move on. Ideal preparation time, if you're asking me, it totally varies. That's why I don't want to answer that particular question, because everyone has their own different scenarios. Some are single, doesn't have any, no children, no spouse to take care. Their situation is different from someone who works full time, has children, and has a spouse. It's different, and they need more time because you are not as free as that first person. A person who is in Australia and not working currently, his or her scenario is different from someone who is working in their country 12 to 14 hours in a day. So it totally varies. Someone can be a slow learner and someone can be very fast learner. So that's another variation. So it totally varies depending on everyone's particular scenario. But if you ask me minimum time, I always say at least 6 months is must. So 6 to 8 months should be your preparation time, but it always depends on all other factors as I discussed. Okay? So our course is about 5 months, but we provide all the materials that you need from the start of the course. Even the previous batch records, like the batch that we are taking right now, the previous batch whole class recordings will be provided to your portal. So even if you say that, no, I have a lot of time and I don't need 5 months to prepare, I can prepare earlier than that. You can also do that by going through our previous class recordings. And you can finish this course even in 2 months. So we always do that in case someone asks that, yes, I have a lot of time to prepare and I want to go faster. So you have the choice of doing that. But if someone they don't have enough time, this 5 months course is very well balanced to prepare for your exam in a way that you can do everything that you are doing and you can still prepare your exam. Okay? And then at least take 1 or 2 months to go to revise what we have discussed, and then you go for your exam. Okay? So I would think that if someone starts our course in this March, they should go for the exam in October or November if they are giving time and if they are doing their hard work. Okay? Even if you are doing faster, then you can even go maybe July, August, or September. So it's how fast you can prepare for this exam that matters. Okay, I think we will discuss about the class, the course materials and everything just at the end of our tonight's session. Let's start the class so that you don't think I'm just discussing about the course and I'm not doing any classes. So let's do some class and then we will again go back to that. Okay? Psychosocial history. For any kind of mental status exam, psychosocial history is must. So psychiatry, you get most of the time 2 questions in the exam. So 2 questions from psychiatry, 2 questions from gynae and ops, 3 to 4 from physical examination, and others will be from medicine and pediatrics. So that's how usually the exam questions are divided, but it can vary. Sometimes you can get 3 psychiatry questions. So it can vary, but most of the time you get 2 psychiatry questions, 2 questions from gynae and ops, and sometimes 2 or 3 from pediatrics. The rest of them will come from physical exam. So physical exam usually 4 cases. Sometimes it can vary from 3 to 5. And then rest of them will be medicine and others. So psychiatry is important in a way that you can pass those 2 cases very easily if you know how to do the psychosocial history. Because most of the cases you will require to do this history part. And psychosocial history, it's the basis of any psychiatric question. So if a patient comes to you feeling very sad, your first task in the exam would be take a psychosocial history from the patient. And the second task will be give your mental status findings to your examiner. So tonight's session is mainly focused on mental status exam, how to give mental status exam information to the examiner, and how to take a proper psychosocial history. That will be our focus. Any psychiatry questions, your history always should have confidentiality statement at the first. So let's say your initial 2-minute time, you have read the question and you have thought what you're going to ask in this station. Then your 2 minutes is up, and after that your 8 minutes starts. So how you are going to start your history? So let's say the patient's name is Sam and your name is X. So you can always start in a conventional approach or with an alternative approach. And I'll show you both, and you will decide which one is best. The conventional approach is used by everyone because it is given in every kind of notes. Alternative approach is our approach, which we ask you to do. So conventional approach would be, hi Sam, this is let's say this is Dr. Arshan. I'm one of the GP in this clinic. It's very nice to meet you. I understand from the notes that you're feeling very sad lately. I'm going to ask you a few questions about this, but let me assure you that whatever we are going to talk today will be between you and me unless it is harmful to you or others. So this is called confidentiality statement. Now that's very, it's been like this for a long time. In AMC, everyone says this line. So examiners, they get very bored about this line. And every time someone open up with this, examiner know that you might have just read Karen notes or you might have just read some other notes and they don't like it. So we are using a bit of different approach so that you don't sound like everyone. So you can always say, Sam, like, hi Sam, this is Dr. Arshan. I'm one of the GP in this clinic. It's very nice to meet you. Sam, I can see you are really sad. I'm so sorry to know that. I want you to know, Sam, that we are here to help you. You can tell me what's making you really upset. Sometimes things doesn't go as we plan, but it's not anyone's fault. And I'm sure that we can help you. I'm here with you unless you are ready to talk. And I want you to understand that whatever we are going to discuss today, it is confidential between you and me. So whenever you feel that you want to talk to me, please tell me what's making you sad these days. Now you can understand the difference between this approach and the conventional approach. So like if you use these lines, there is no role player in your exam who is not going to open up. Because you need your role player to give information. Because if your role player doesn't talk, and they can do that in psychiatry, if they don't like your approach, they will just be shut. They will not give any information to you, and that is permitted. If you don't give confidentiality in a psychiatry case, they are permitted not to talk to you at all. So 8-minute time, they might not even open their mouth. So you will know that you have done something wrong in that case. So to avoid those kind of scenarios, I would suggest use our approach and be very gentle and polite. Your change of voice, change of tone when you are talking to a patient matters a lot. You can't just smile to a patient who is diagnosed with cancer. Your tone of voice should change. So that's what we ask everyone, that what usually first-time candidates does, that they don't care about the patient. Their main thinking in their head is just to finish the task in 8 minutes and pass this station. And that's wrong. If you think in their head that it is all about finishing the task, you are wrong. It's all about your approach to a patient and how better communication you have. Okay? And every time you finish your exam, the examiner will ask to the role player that, do you like this patient? Do you like this doctor? Okay? And if that role player say no, if you have done everything right, still you will fail that case as a global score. So it is very important to make sure you have a proper, gentle approach to your role player. They have the highest priority in the exam. Okay? So once you have started like that, most of the patient will open up. And then you can ask, so you have already asked the patient that, can you tell me that what's making you sad these days? So patient will give you an idea or some information, like maybe sometimes they can say that, well, I am a vet and recently I killed one of the cat, and I know that I am a murderer and I don't deserve to die, so I don't deserve to live. So when you hear something sad from a patient, you just don't continue your question. When something sad coming from a patient, you say sorry. You say, I'm very sorry to hear that. It must be very difficult for you. Now, Sam, would you tell me how's your mood these days? So now you are going to your history. Until that, you are allowed to be a little bit slow. But once you move on, then you can be a little bit faster so that you can finish the case in due time. So your psychosocial history, the format is like that. So you can ask mood, sleep, appetite. Then you ask suicidal question. Sometimes we add some questions related to our particular diagnosis. Like this patient is sad, so we will ask some depression related questions. If we think that this patient having psychosis, we will ask psychosis related questions. If we think this patient might have mania, we will ask mania related questions. So it is different. We will know from the stem that what this patient most likely having. A sad patient most likely is depressed. So you'll start with the mood question. So how is your mood these days? Sometimes we can also ask that, is there any time that your mood is very high for a short period of time, to rule out bipolar disorder? Sometimes we see that a lot of candidates ask that, how will you score your mood in a scale of 1 to 10? I don't like that question. It is something so variable that many of these patients can't put it in a score. Like your mood, is it good, bad? It's very hard to say the score. So I don't like that scoring part. So you can just say, how's your mood these days? And patient will say low and frustrated. Then you can ask, is there any time when you feel very high for a short period of time? Patient will say no. Then you will go, so how is your sleep and appetite? Now, if there is anything positive, we ask a little bit more detail. Like if a patient say low mood, you would definitely ask how long you are feeling this way, because you need that duration to diagnose a particular condition. So always ask the duration of symptom. Same in here, if there is a sleeping problem, patient say, I can't sleep. You will ask a detailed question about it. So you will say that how long you're feeling this way. Do you have difficulty falling asleep, or you wake up early in the morning? Difficulty falling asleep usually happens in anxiety patient. Early morning wake up, depressed patient. You can also ask that, is it hard to go back to sleep? Depressed patient will also have hard to difficult, or like they will have difficulty to go back to sleep. You can also ask, do you get multiple broken sleep at night? If they say yes, then you ask the question of nightmares. So do you get nightmares? Patients who suffer from post-traumatic stress disorder, they get nightmares a lot and get multiple broken sleep. So if you get a sleeping problem history, then you will ask all these questions, that is it difficult to fall asleep, or you get up early in the morning? If they say get up early in the morning, then you can ask, is it difficult to go back to sleep? They will say yes. Then you can also ask, do you get multiple broken sleep? If yes, then do you get nightmares? So it's all about asking questions based on what history you get from the role player. So far you asked about mood, sleep, and appetite. Then you will ask about suicidal question. Suicidal question is must for any psychosocial history. Everyone who you are asking a psychiatric history, we always assess the risk of suicide. So it's must, and it's a key step in the exam. So you can ask the patient, do you think life is worth living? If they say no, then you will ask this question. So do you have any passing thoughts of harming yourself or others? If they say yes, then any definitive plan to commit suicide? Any previous attempts? Okay. So that's your suicidal question. So you have asked mood, sleep, appetite, suicidal question. Now, if you think this patient might have depression and your task is to talk about diagnosis and differential diagnosis, then you can ask about some depression related question. We will discuss later on what are the depression related question. We follow the mnemonic M size caps. So M size caps that include, I'm sure in MCQ you know about M size caps. So M for mood. So you have already asked about mood. S for sleep, you asked about it. I for loss of interest. So you can always ask the patient that, do you still enjoy the things that you used to enjoy before? Or directly you can ask, have you lost interest in things that you like? G for guilt. Do you feel guilty about anything? E for lack of energy. So do you feel very fatigued and tired these days? C for concentration. So any loss of concentration and attention. A for appetite. So you can ask any loss of appetite or loss of weight. P for psychomotor retardation or agitation. So you can ask that, do you think you have slowed down on things? So psychomotor retardation means patient will get slowed. And S for suicidal thoughts, which you are asking anyway in here. So this is M such cats. You will only ask this additional question if the task is diagnosis and differential. Otherwise, you would not ask this depression or any of these specific questions. If your task is mental status examination, like you have to discuss the MSc finding to the examiner, then you don't need to ask these questions. Okay? So you have done the initial part, then you are going to say, Sam, I'm going to ask you some screening questions that may seem quite strange to you. Is that all right with you? It is particularly important before you ask about these psychotic questions, hallucination and delusion. So for hallucination, do you see, feel, or hear things that others don't? So seeing means visual hallucination, feeling is tactile, and hearing means auditory hallucination. So ask these questions. Then you have delusion question. So for delusion, we follow the mnemonic RCGGP. So RCGGP means R means delusion of reference, C means delusion of control, G means delusion of guilt, another G means delusion of grandiosity, and the P means delusion of persecution or paranoid delusion. So delusion of reference, control, guilt, grandiosity, and persecution or paranoid delusion. So how you are going to ask these questions? So first question about paranoid delusion. Do you think someone is spying on you or trying to harm you? For control, do you think someone is controlling you? For reference, do you think people are talking about you? G for guilt, do you think you are guilty of something? And another G for grandiosity, do you think you have some special power? Now, we don't need to ask all these questions to every MSc. Someone who most likely having depression, we don't need to ask about this paranoid delusion or delusion of reference. Those are not important for them. For them, delusion of guilt is very important because most of the depressed patients, they have like a severe guilty feeling. But someone who you think having psychosis, for them, these delusion questions are important, like delusion of persecution, control, reference, grandiosities. These are all important for psychotic or schizophrenic patient. Particularly, this delusion of grandiosity is important for mania patient. Okay, so based on your stem or the case, you will always know which one is must to ask. Apart from these RCGGP questions, we also ask few other deduction questions. One of them is, do you think someone is inserting or withdrawing thoughts from your mind? So this is called deduction of thought insertion or thought withdrawal. Do you think your thoughts are being broadcasted in TV, newspaper, or radios? So this is deduction of thought broadcasting. So this thought insertion, thought withdrawal, thought broadcasting also can be found in a schizophrenic or psychotic patient. So these are all very important, and any findings can be given in your exam. So you'll have to ask these questions so that the findings, you can get those findings from the role player. Okay? Clear so far, everyone? Any particular questions that you are struggling? All right, so once you have done the deduction questions, your next questions will be insight, judgment, cognition. So for insight, we ask, do you think you need some medical help? For judgment, we ask just, let's assume that there is a fire in this room. What will you do? Patient who has lack of insight or psychotic, they will not have insight or judgment. So they might say, well, I will stay in this room. Fire will not touch me. So that's lack of judgment that can be found in these patients. So insight, judgment, and cognition. So we ask the cognition in terms of place, time, and person. So we ask the patient, do you know where are you at the moment? So that's place. Do you know what is the date today? That's time. And do you know who I am? That's person. So usually if we are assessing cognition of a person, we ask time, place, and person. Okay? So you have done insight, judgment, and cognition. After that, we have HEADS, SADMA, past medical history, and family history. So what is HEADS? HEADS is very important for any kind of psychosocial history. HEADS gives us an idea about a patient's home situation and work situation. So there is a lot of things in the HEADS, but we mainly focus on home and work. So H for home situation, E for education or employment, A, you can think about activity, D for drugs, S for social support, and another S for sexual activity. So we mainly focus on home and work situation and support. So you'll ask the patient, how is your home situation? Is there any stress at your home or at your work? Do you have enough support? We can also ask any financial stress or any financial issues. So again, heads include home situation, employment, which is work situation. A, you can think of activity, not important. D for drugs, which also important. And D, sometimes we also include diet, which is not important as well. S for support, and another is for sex. So we just ask about support, home, and work. That's it. Then you have SADMA. SADMA also, it's mainly about smoking, alcohol, and medication. So S for smoking, A for alcohol, D again, we keep it for drugs. M for, now this drug is recreational drugs, not the actual drug. M for medication, A for allergies. So you can ask, do you smoke or drink alcohol? Any other recreational drugs? And then you can ask, do you take any medication regularly? Any known allergies? Now, medication allergy is not must to ask in a psychiatric history. Ask about past medical history. So how is your general health? Any other medical condition that I should know of? Any past history of any mental illness? And any family history of mental illness? We also try to rule out any organic cause, which means if this kind of presentation has any relationship to any organic problem. So the organic causes which mimic psychiatric problem are thyroid problem, recent head injury, and recent flu-like illness. So you can ask the patient any change in your weather preference, that's for thyroid, any recent head injury, any flu-like illness. Again, this organic history is not must in a psychiatric history. So if I give you the format of psychosocial history, it will be like this. So first, confidentiality. Second, you will be asking about mood, sleep, appetite, suicidal risk, hallucination, delusion, insight, cognition, judgment, HEDS, SADMA, past medical history, family history. Now, this is the only thing that you will remember in your head, nothing else, because other things, it will come to you once you start doing a lot of role plays. So the format is all that matters. In the exam, you can't remember every case separately. How we make your preparation concise and well structured is that we give you a format of particular cases. So with one format, you can finish 10 cases. So that you don't need to memorize or you don't need to know approach of 10 cases separately. So with one format, you can utilize that format for, let's say, at least 6 to 10 cases. So that makes your preparation much easier and shorter and very structured. And there is something which a lot of students don't do. All right? So that gives your psychosocial history. Once your history is done, you will thank the patient and then you will go to the examiner to give the finding of your mental status exam. How you present mental status exam to the examiner, we always make sure we include this aseptic J3R. Before we move on to that, do you guys have any questions from psychosocial history? What causes difficulty falling asleep? Anxiety. So anxiety, generalized anxiety disorder, adjustment disorder, those patients will have difficulty falling asleep. Should we ask further if patient answered yes to the question that do you think life is worth living? No. Then we don't need to ask further question. No questions for history, guys. You're good? Now, many patients are designed in that way that they will not respond well to your questions, Dr. Maushami, and that's fine. As long as you are getting answer from them, you're getting your findings. So psychiatric patients might not answer questions very promptly. They might not behave like politely with you. That's how the case is designed. So you don't take it personally. You just make sure you get the findings that you need to present the MSc to the examiner. And it's not like that they will not give the information. If your approach is good, they will give the information that you need. Okay, so all you need to do is to follow this format. Make sure you give a proper confidentiality statement, then you will get the findings. So if a patient say, yes, I feel guilty, then definitely you need to know what the feel, like why he is feeling guilty and what kind of guilt he is having. Right, Dr. Hari? So let's say a patient says, yes, I feel guilty. So you will ask that, well, can I know that, like, what kind of guilt that you're having? So we need to know those things. So you will try to find out based on the finding. Okay. Now, You can ask questions if you still want to, so you can write it on the chat box. But now I am moving to MSc format. So your first task is done. Once your first task is done, you will thank the patient, and the next task is present MSc to your examiner. So how to present mental status exam finding to an examiner, that's really important to know. So you will be using this format, aseptic J3R. So aseptic J3R is the mnemonic which include A for appearance and behavior, S for speech, E for emotion, which includes mood and affect, P for perception, T for thought form. There is two T. Another T is thought content. I for insight, C for cognition, J for judgment, and then there is 3R. 3R include risk, rapport, and reliability. So this is your format for MSc presentation to your examiner. Now we'll be discussing about this in detail, what this actually means. So once your history taking is finished and your MSc presentation is your next task, you will be saying in this way. So you'll thank the patient and then you will say, thank you, Sam, for all the information that you have given. Now I'm going to talk to my examiner and come back to you. So dear examiner, I would like to present the mental state examination of my patient, Mike, a 35-year-old vet found by his partner trying to hang himself in the garage. So that will be given in the history. Then you will start with appearance and behavior. So how the patient's appearance and how is the patient's behavior when you are asking the history. Appearance and behavior include the dressing of the patient, if the patient well-groomed or unkempt. So if the patient is dressed appropriate to the weather, if patient is well-groomed or unkempt, if the patient cooperative or not, if the patient maintaining eye contact, and if there is any abnormal body movement or posture. Abnormal body movement can be stooped posture, which is like leaning forward, can be found in a depressed patient. They can have constant frequent fidgeting, which is found in anxiety patient. Patient can be restless, agitated, can't sit in one place, roaming around, that's mania. Sometimes you can see that while you are talking to the patient is looking maybe at the ceiling as if he can see or hear someone else. So that's distracted and seems to be responding to some unseen stimuli, which can be found in schizophrenia patient. So these are the abnormal body movement or posture that you can find. So initially you will be saying that in terms of his appearance and behavior, my patient is dressed appropriate to the weather, he is well-groomed, he was cooperative, but he was not maintaining eye contact. Patient who is depressed, they usually don't maintain eye contact. He was sitting in a stoop posture, but there was no restlessness, and the patient did not seem that he was distracted. So we also give some negative finding so that examiner know that we are looking for these findings, which is important. So some positive findings and some negative findings. That's given in all this appearance, behavior, and everywhere. Okay, so this is appearance and behavior that you will be looking for. So dressed, well-groomed or unkempt, cooperative or not, maintaining eye contact or not, and if there is any abnormal body movement. After that, you have got aseptic, right? So S for speech. How was the patient's speech? Was it normal in rate, volume, and tone? Or was it very slow and monotonous? Or it was rapid pressured speech? So most of the patients, they might have just a normal rate, volume, and tone. But patient who is depressed, they will talk very slowly and they will have a monotonous speech. So the only thing they will say is yes or no. So do you feel sad these days? Yes. Do you have any guilty feeling? Yes. So they will not say anything else. So that's called monotonous. And they will be quite slow to start talking with. So slow and monotonous can be found in a depressed patient, whereas rapid pressured speech, like very rapid, loud, pressured speech, can be found in a mania patient. Depression patient can also take a long pause in between their talking. So they will be taking a long pause. Mania patient, they might not answer your questions appropriately because they will be quite restless. Psychotic patients can have disorganized speech, like you don't even understand what the patient is saying, which is unlikely to find in your exam because they need to give you the finding. So speech, most of the time, either it will be normal in rate, volume, and tone, or it can be slow monotonous, or it could be rapid pressured. After that, E. E for emotion. Emotion include mood and affect. Mood is when you ask the patient, how's your mood these days? And patient says low. That's mood. What is affect? Affect is what you see when you are talking to the patient. Do you think when the patient is talking, he looks sad and gloomy to you? If it does, then his affect is congruent with his mood. But someone saying, no, I feel really good. But when you talk to the patient, you can see that patient is disturbed. So patient is like, you can't understand what he's saying. You can't actually make any sense out of that. So that means he's saying his mood is fine, but the affect that you are observing is disturbed. So these are the two things that can happen. So basically mood is what patient says and affect is what you observe in that patient. So in depressed patient will say, yes, my mood is low. And most likely you will also observe that patient is actually he is sad. So you can say that according to the patient, his mood is low and the affect that I have observed is congruent with his mood. Okay? So that's your emotion. Then you move on to P. P for perception. Perception is included in hallucination. So the hallucination question that you ask, that will give you the perception finding. So if there is any hallucination positive, then you can say that patient's having auditory or visual hallucination. So far you have done appearance and behavior, speech, emotion, perception. Now you have 2T, thought form, thought content. What is in thought form? Thought form means that if a patient answers your questions appropriately and you can understand those answers, it means patient's thought form is normal. And the normal thought form is called linear thought form. Again, if you can understand patient's answer and patient giving appropriate answer to your question, that means patient's thought form is linear. All right? What are the abnormal thought form? Abnormal thought form can be loosening of association, can be tangentiality, circumstantiality, concrete thinking, flight of ideas. Now, loosening of association is usually found in schizophrenia patient. Same all others like tangentiality, concrete thinking. These are schizophrenia finding. Whereas flight of ideas is a finding of mania. How to differentiate between loosening of association and flight of ideas? That can be quite confusing in the exam. So I'll give you some example, then you should be able to understand. So loosening of association means that whatever patient is saying to you, there is no specific meaning of that. Let's say you ask the patient, that where are you going? Or you ask the patient, do you know who I am? Patient saying that, yes, doc, I know my teacher. I know that I went to the market in the morning today. Oh, I should read that book. That movie was really good. My rent is due. I feel that I need to have a chocolate. It's a lovely evening. Now, patient is not answering your question. He's just talking and talking without any association in between two sentences. The loosening of association divided into tangentiality and circumstantiality. Circum, you can think of circle. So that means if you ask a question, patient will talk and talk and talk, but at the end, he will answer your question. So at the end, he might say, oh, you're the doctor. But tangentiality means patient will talk and talk and talk and never coming back to your question. So that's tangentiality. So this is part of loosening of association. So that's what you can find in a schizophrenia patient. But in the exam, you would never get a loosening of association patient, because in that way, they can't give you the finding. Because you need to get finding from the role player for this MSc examination. So in your exam, you would never get this. What's flight of ideas? Flight of ideas means patient jumping from one topic to another, but there is still a little bit of association. But they will jump from one topic to another. Like this one, I loved that movie. I'm going to watch a movie with my mom. My mom adores me. So every sentence, patient is jumping. Loved that movie. Watching a movie with my mom. My mom adores me. So they're jumping, but there is a little bit of association between each of them. That's flight of ideas. So rapid shift in conversation, that's what we call as flight of ideas, which you can find in a mania patient. Making sense for everyone? Good. Next, thought content. Thought content includes the delusions that we ask. So if there is any delusion that you have found positive, you can add it here. So if there is a delusion of reference, if there is a delusion of control, then you can say it here. In thought content, we also include any overvalued ideas like eating disorder or body dysmorphic disorders, or if there is any OCD findings, these will be also added in thought content. So obsessional thoughts, eating disorder thoughts like overvalued ideas, body dysmorphic disorders, these will be also included in thought content. But mostly it's the delusion that we look for. So far you have done 2T. Now you have got aseptic J3R. So ICJ. So ICJ means insight, cognition, and judgment. So if the patient insight is poor, you will say patient insight is poor, judgment is poor. And how about cognition? In cognition, you'll be looking for if the patient is oriented to time, place, and person. So insight, cognition, judgment is done. Then 3R. 3R is risk of the patient. So through your history, you will know if this patient high risk or low risk. If a patient has got active suicidal or homicidal thought, or active hallucination or delusion, that patient is high risk. If they are not suicidal, they don't have a hallucination delusion, then low risk. Then there is rapport. Rapport means how was your relationship with the patient during that 8-minute time. Now, it doesn't mean that you will always have to have a good relationship with the patient. Many psychotic patients, they will be rude to you. They might not answer your questions appropriately. Then you will say, I was not able to maintain a good rapport with my patient. If your patient was gentle and polite with you and you had a good conversation, you can say that you were able to maintain a good rapport with the patient. And it's not a negative mark that if you can't maintain a good rapport. Okay. Then there is reliability. Reliability means the history that was given by the patient, is it reliable? Remember one thing, that if a patient has lack of insight, lack of judgment, or patient is actively suicidal, or patient having active hallucination, delusion, those patients' history is not reliable. So you'll need to take a collateral history from a family member or whoever accompanying the patient in the hospital. Okay? So 3R include risk, rapport, and reliability. So that brings your finishing of MSc presentation. Now I'm going to give you an idea how you are going to say that to an examiner. So you will say in this way, dear examiner, I would like to present the mental state examination of my patient, Mike, a 35-year-old doctor found by his partner trying to hang himself in the garage. In terms of his appearance and behavior, he is dressed appropriate to the weather, he is well-groomed, cooperative, and he was not maintaining appropriate eye contact. He was sitting in a stooped posture, but there was no distraction or frequent fidgeting. His speech was slow and monotonous, but there was no rapid pressured speech or disorganized speech. According to the patient, his mood is low, and the affect that I have observed congruent with his mood. He did not have any perceptual disturbance, so there was no auditory, visual, or tactile hallucination. His thought form was linear, there was no loosening of association or. In terms of thought content, he did not have any delusion. His insight was poor, cognition was poor, but he was oriented to time, place, and person. He is high-risk patient because of active suicidal thought. I was able to maintain a good rapport with the patient, but the history that was given is not reliable. So I would like to take a collateral history from his family member. Thank you, examiner. You don't need to give a diagnosis unless it is asked in your task. So your MSc presentation will finish here. So that's pretty much how your task will be. Now, I understand that it is difficult to finish in 8-minute time, but trust me, once you start doing role plays with your partners, then it will make sense and it will become much easier. It is also better that when you first start your 8-minute time, in the 8-minute time, when you start it, you can write aseptic J3R on the paper that will be given. So you can keep a pen and paper in front of you and you can write aseptic J3R on the paper. Not in the initial 2 minutes. You can't write anything in the initial 2-minute reading time. But once the 8-minute starts, quickly you can write it, and just when you are taking the history, you can write the findings that you have got, because you can easily forget your finding. So it's better to write. If there is a auditory hallucination, just write auditory. Okay, if the patient say mood is angry, just write angry. If you have got, let's say, lack of judgment, so just cross judgment, insight poor, cross it. So whatever finding you get, write it in the front so that it becomes easier for you to remember during the MSc presentation. Okay, so that's your psychosocial history. That's how you present MSc to an examiner. Is this clear for everyone? Okay, very good. Now we are going to take a 5-minute break. After 5-minute break, we're going to do a role play, and you will see that how this actually works in the exam. Okay, so role play is it's important to know how to prepare for this clinical exam. Okay, so let's take a 5-minute break, and after that we do a role play of a case, and then we will go into further discussion about the course, further discussion about the clinical exam. All right, thank you. All right, everyone. So let's start again. Any questions? So can we say to the examiner that patient was rude? No, you can't. So just say that you couldn't make a good rapport. Okay, there's gentle way of saying that. When we are presenting AMC to the examiner, can we present while looking at the paper where we have already written? Definitely, you should not just look on the paper. You can always just have a very, like, before you present MSc to your examiner, you can just have a quick look and then you can start your MSc presentation. And sometimes while you're talking to the examiner, you can look at the paper. So it's not like you will just look at the paper and then you will give the finding. It doesn't look good. Okay. Now I want to do a role play with one of you. So if any of you are a little bit prepared and you have done role play a little bit, so if you want to do role play now, just write yes on the chat box and we can do a role play. I'm just stopping sharing my screen while we do that. So any of you who wants to do a role play? Dr. Sherry, let's do that. So I'll just unmute you.
Hello,
Dr.
Dr.
Sherry,
Ashkan.
can you hear me?
Yes.
Yes, I can hear you. How are you?
I'm fine, thank you.
All right, so let's do this case.
Okay.
So this is your case. You'll get 1 minute to read this case and think of the case. And then we'll do 7 minute 30 seconds. So best is to do 7 minute 30 seconds as when you prepare, but ideally you will get 8 minutes in the exam for your role play. Okay. So your time starts now. Okay, so this is your patient, David. You can start.
Hello, Mr. David. I am Dr. Sherry. I am one of the doctors here. I
There
understand
is
from
lots
the
of
notes.
cockroaches in this room. I can't stay in this room. This bloody room is full of cockroaches. Just let
I'm
me
sorry.
out of this room, though. You are the
I am
doctor,
sorry.
right? In here, are you? Where
Yes,
is the
Mr.
cleaner?
David.
Why
Appreciate that.
why a
I understand
surgical patient?
it's not good
Why
because
I'm
you
here
see
in this room?
she's around
This
you.
room is full of cockroaches. Just let me out. I can't stay in this room. I am a surgical
Okay.
patient. I had my
I
shoulder done yesterday and there is cockroaches all over. What if I get infection from these cockroaches? What are you going
I
to do
understand
about that? Why don't you call
how
the
you
cleaner just now?
I will do all what I can do to fix this problem, Mr. David. Please let me help you. Before I talk with you and fix this problem, I would like to reassure you that everything we
Just get
discussed
away.
today is confidential between me
Get
and
away.
you.
All these cockroaches on my hand, my God, they're crawling on my body. Just go away.
I understand this is very annoying, Mr. David. I am sorry for that. Can you tell me how is your mood, Mr. David?
You can
Do
understand
you
my mood. This room is full of cockroaches. How is my mood? I'm angry. I'm frustrated. I have done my taxes throughout my life, and I shouldn't be treated this way.
I'm really sorry, Mr. David, for that, and I promise we will fix this. Mr. David, how long have you been feeling? How long have you been seeing these cockroaches?
Since the morning today, it's all over the room.
Okay, and is there any pain after the surgery?
No, I can't even feel anything, but this cockroaches is making me crazy. I just want to leave this hospital. No one
I
should come
understand
here.
this is difficult, Mr. David. And how is your sleeping? Did you sleep well?
Yeah, but the cockroaches just wake me up, just all over my bed.
And how is your appetite? Did you start eating?
Yeah,
Okay, good. Do you think life is worth living, Mr. David?
I do. Otherwise, I would just leave from here straight away. Oh, there is cockroach on your shoulder, doctor. Just have a look. There is a cockroach.
Do you only see? Okay, do you feel them as well, Mr. David? Do you feel them on your skin as well?
Yes, this is all over my skin. There is one on your shoulder as well.
Do you hear them, Mr. David? Or do you hear others does not hear?
Oh, doctor, do you think I'm a crazy person? How can I hear cockroaches?
No, I'm just asking. I'm sorry, Mr. David. I will ask you some screening questions that might seem strange. Is it all right with you?
Yeah?
Do you think you need medical help, Mr. David?
No, but I need help from a cleaner. That's definite.
And do you know where we are now?
I'm in the hospital.
And what is the time today?
I don't know. Is it Sunday?
Do you think others are spying on you or trying to harm you?
No,
Do you think others are controlling you?
no,
Um, do you think others are talking about you?
no,
Do you think you have special power?
no, doctor.
Do you think others are inserting or withdrawing thoughts from your mind?
No, doctor. What kind of questions are these? I know that these are important for you, but why is the cleaner? The cockroaches are coming to me. It's just on my body. I can't stay here. Just let me out. Let me get
I
out
know,
of this room.
I know I know that, Mr. David. It's very annoying, and I promise we will fix this as soon as possible. Do you think your thoughts are broadcasted on TV or television?
No,
Mr. David, if this room has a fire now, catch a fire now, what will you do?
there is a fire in this room. Now there is a fire, and then there is a cockroach.
No, I'm just saying if there is a fire, what will you do?
Yeah, I will just run.
Okay. I'm done, Mr. David, and I thank you for talking to me, and I will now talk to the examiner.
Okay.
Dear examiner, I would like to present the mini mental state of my patient who had surgery yesterday and who was reported seeing cockroaches and was aggressive and difficult to settle. His appearance is well dressed to the weather, but he appeared angry and aggressive. He appeared agitated. His speech was rapid and his mood was angry and his affect was congruent to the mood. He has visual and tactile hallucination. There was no delusion of reference or control delusion or grandiosity or persecution. No withdrawal. No thought withdrawal or broadcasting. The thought form was linear. He has no insight, or his insight is impaired. He was oriented to time, place, and person. His judgment was good. I was able to maintain good rapport. The history was the risk.
Time up. Thank you,
He is
doctor.
high risk as
Okay, it's very good, Dr. Sherry. Yeah, it's a high risk, right? Yeah, that's definitely. And do you want to take a collateral history or not?
Yes, I wanted to take collateral history because he has delusion. He has perception. He has hallucination of yes, tactile and visual hallucination.
Okay. That's all right. Very good, Dr. Sherry. You have done it very, very good, and you haven't missed any specific finding. So that's perfect. Okay. So definitely you can't talk about the appearance in here because you are not seeing me. But in your exam, you will be able to have a look. So that's all good. Now let's come back to the history. So your history was perfect. You didn't forget about the confidentiality, which was good. I would suggest not just you, for you, allow the patient to talk, because when I was talking, you were also talking, and that's not a good approach in the exam. So allow the patient to talk. At some point, patient will stop. And when the patient stops, or at least he needs to take breath, when he stops to take breath, that's the time you hop in and you start your question. Okay, so don't talk when patient is also talking. That's very important thing. Otherwise, in the approach, they will make you fail. Never say promise in the exam. Okay, so you have said, I promise that I'm going to clean this room. Never say that. It's not a good thing to say to the patient. We never promise anything to a patient. So that's number two. Otherwise, approach was very good. Confidentiality was taken, and you didn't forget the format. So you asked everything that's needed for this case. Because your task is mental state examination, even though you haven't asked about heads, SADMA, past medical history, still you will pass the case because it's not must in here. The must thing is to ask about aseptic J3R. As long as you're asking those important findings and you're presenting that in time, you will pass the case. Okay, so if you're running out of time, you can forget about heads, SADMA, everything. Okay, but you will have to ask about insight, cognition, judgment. Those things are must because that's your finding in the exam. Okay. In your MSc presentation, I think you haven't missed anything. You talked about speech, emotion, perception. Yes, this patient had a visual and tactile hallucination. Thought form was linear. Thought content, there was no delusion. Insight was impaired. Cognition was okay. Judgment was all good. Then this patient is a high risk because of active hallucination. Rapport, you can say that you were able to maintain a good rapport, and this is not a reliable history, so we have to take a collateral history. Okay. So this is how a role play works for everyone who was wondering what's role play. This is how it is. So you will need a study partner, and with the study partner, you will need to just one of you will become patient and one of you will become examiner or candidate, and you will be doing these simulated cases. That's how you learn. Okay. And as long as you do that, as much as you do that, every time you will get improved. So if you just ask me that I don't have any partner and I can't have a partner because I work all day and there is no steady partner who is going to do role play with me, that's really not a good idea, because for passing AMC clinical exam, everyone needs a steady partner to do role play. Role play is must. There is no other way to pass this exam. You can have every note in the world. Still, if you don't do role play, likely chance of passing the exam is very low. Okay. So get a steady partner. When you join the course, you will get a partner anyway, because there is a huge number of candidates who join our course, and you can find someone in your country or in your time zone. Okay, so we'll help you with that, so no worries. Now, in these kind of cases, when a patient says that there is cockroaches in this room, why I'm been treating in this way, you can always say how Dr. Sherry said. So you always, I'm very sorry, it must be very annoying, and I'm sorry that's happening with you, but I'm calling the cleaner right now, and this room will be cleaned as soon as possible. But if you can please answer my questions during this time, I would really appreciate that. And I want you to know that everything that we are discussing, it is confidential. Okay? We don't need to offer another room, because if he goes to the other room, he will also see cockroaches there. So it's not a point. And yes, we have to present to the examiner in this 8 minutes. Even if we are unable to get proper history, yes, that's right. So timing is very important for this exam, because if you are not quick and if you keep on thinking in your head that what will be my next question, you will not be able to finish this task. So that comes with a lot of role play. Initially, you will not be able to finish this in time. Once you start doing multiple role play, you will know. You will get into the time. You can't see any watch in the exam, so you would not know how much minute is left. So they don't allow you to keep any watch on your hand or any watch on your room, and that is something illegal to have. And in exam, the invigilator will ask you to show the room around, and if they find any watch, they don't like it, because it is illegal to have any watch in your room during your exam. Okay. And Dr. Thanuja, don't we have to ask about alcohol? The thing is that you don't need to talk about diagnosis or differential diagnosis in this question. If there was a task of giving diagnosis and DD, yes, then you had to ask about alcohol history. You had to ask about some of the differential diagnoses at that time. But at the moment, it's not relevant. Do we need to pretend to give a call to cleaner? No need. You just say. Can we agree with the patient that we are also seeing cockroaches? No, we would not say that. We will be smart. We will not answer that question. Okay, we will always say, I'm sorry that you are feeling this way. When patients say there is cockroach on your shoulder, you can say, thank you for showing that to me. That's it. You don't say that you are also seeing it. Or like some candidate, they say, yes, I can see the cockroaches. That's bad. Is there a timer on the screening? No, there will be no timer. So you never know the time. How you will get adapted by doing role play, you will know the time in your head. It's all about preparing yourself, and like throughout the history, there was never watch given in AMC. So everyone passed without a watch and a timer. So you will also be able to do that, but you need preparation. Okay. Now, alcohol history, Dr. Arpita, only needed if there is a, like if you have more time left and patient was not giving you a hard time, then you could ask about alcohol history here. But you have to ask if there was a diagnosis and DD, because it could be an alcohol withdrawal causing delirium. Okay, so that could be your diagnosis in this case. Here the patient saying seeing cockroaches. Should we explore this further? Like what kind of exploration we want to do? Patient seeing cockroach, that's more than enough. We only need to know how long you are seeing this way, and we only need to know, like, are you able to hear any voices, or do you hear any voices? Don't say that, do you also hear cockroaches talking to you? That's not needed. Just say you are hearing any voices, and do you also feel the cockroaches on your body? That's for tactile. Yes, so within 8 minutes, you have to take a history from the patient and also present the MSc to the examiner. Now, Dr. Ghaffar, you will not have that much time in the exam to go that much detail where in the body you are feeling that. That's not relevant and not needed. So we will stick to the relevant thing in the exam. Does it matter if the patient is feeling it on the face or on the leg? Doesn't matter. He's feeling it, that matters. Do we get prompt by the invigilator? Good question, Dr. Navar. So the only time you will get a prompt by invigilator, if in the task it is written, take history for 4 minutes. So if the time is written on the task, then after 4 minutes, there will be a prompt from the invigilator. Like your 4 minute is up, move to the next task. But if there is no time written, then there will be no prompt. All right. So that brings us to the finishing of Psychiatry MSc. Our next session, which is free 2-week session, starting from 10th of March. We will start with the first class will be MSc role play. So go through these cases, and then we will have a proper role play on these MSc cases that's important for your exam. There is a huge amount of cases that comes under this format. We will do some role play on that. Okay. Now let's discuss a little bit about the course. And if you have some questions in the end, you can also ask it. So few questions. Cockroaches are just a trap, or it's a prompt to a diagnosis? Cockroach means that this patient having a perceptual disturbance. So it's a hallucination. It's not a trap, it's a finding. Because you know that delirium patient can have hallucination. So this is helping you with the diagnosis. And this is most important finding in this case. When you finish the history, you will say the patient that thank you for all the information. Now I'm going to talk to my examiner and then come back to you. Yes, Dr. Prathiva. If a patient can take long time to answer in the exam, especially for psychiatric cases, and you just need to manage the time. You have to finish it within 8 minutes. So if a patient will not definitely waste your time in a way that you can't finish it. If you think that there is a very less amount of time left, quickly ask the important things and try to say the findings. Okay, so you can always just cut it short. Just the specific questions you will be asking. And Dr. Ira, yes, we'll be giving the recorded sessions of this one on the YouTube, most likely tomorrow. And also it will be given in the First Aid AMC clinical group. So talking about the course, First Aid AMC clinical course is one of the most renowned course for clinical. And you have heard it from maybe from your friends or colleagues, or maybe from someone who passed this exam. And this is how our course usually works. don't advertise the course in a lot of platforms or anywhere, but we'll always get the students from the colleagues or from someone who has done the course. So it means that definitely our students like how we take the course, and that's why you know about this course. There is no other way. So the course has been designed throughout the years and years. It's been 7 years we are taking the course. Throughout the year, it has been updated, it has been improved to the highest possible manner. And the course with its materials has nothing left that can appear in your exam. So we have everything that you need. All you need to do is to give some time for preparation and listen to what we are saying. If you do that, you will pass the exam. So I hope you all know about our official Facebook group, and that's where you have seen the course details. The new course is starting from 10th of March, which is a 5 months duration. The trial class has been happening now, so 2-week sessions will start from 10th March. The schedule of those free 2-week sessions will be given in our First Aid AMC Clinical Facebook group. So keep an eye on that. You can also listen to our previous classes through the YouTube. And this is our firstaidamc.com. This is our website. So if you are looking for the website, this is where it is. So you can write firstaidamc.com and you will get the website. So what the course includes. So we finish everything, as I said. So we'll finish the theory based on cluster-wise approach. And cluster-wise approach is the best way of doing theory. So what we do is that when we do the cardiac questions, you will see the cluster-wise approach in the free 2-week session. In cluster-wise approach, we give you a specific format, like the format that was done today. Using that same format, you can do 6 to 10 cases. So you don't need to memorize history for each case separately. The history will be done, physical examination will have a format. All you need to learn or memorize is that particular case management. So it becomes so easy, so concise and structured that you have a format in your head all the time and you can utilize for those specific cases. That's where we do really good. Once we do a particular cluster, like let's say we do a MSc cluster today, next class we'll be doing role play on that particular cluster so that we know what you're doing, what's you're lacking, and we can give some feedback on your improvement. We also has a portal where you will get all the course materials and the video recordings. In the portal, we have questions from back in 2018. So it's a huge amount of questions collection that you have. And if you have time, you can go through that. But our focus of role play sessions are mainly the recent ones. So we will be focusing on 2024. And sometimes if we have time, we go back to 2023. For a long time, our students were getting only 1 role play sessions in a week. So 4 role play sessions in a month. From your course, without any increase of course payment, we are providing another extra role play sessions and even sometimes 2 extra role play sessions every month. So you'll be getting 6 role play sessions in a month instead of 4 that all our students used to get. So this is a new addition, and we have added another mentor to do that with you so that you can get a variety of questions role play with a variety of role players. Okay, so that's a very exciting thing. We will see how it goes with you. In your portal, you will get videos of all the role play sessions covering the last 3 years. So right now we are doing role play session 138. But once your course starts, it will be around 142 or 144. So you will be getting all those 140 questions or 140 role play sessions that we have taken so far. And that has role play sessions throughout the years. Our students who has now passed the exam, you will be able to see how they used to do role play. And you can learn from them. And obviously we discuss everything the cases that people do role play, we discuss those cases after that. So you will get a discussion on that as well. So if you have time, you can utilize this for a lot of things, and you can understand how this exam works in a very efficient way. You know that physical exam is different than face-to-face. So we usually keep 1 month for online physical examinations. So you will get that as well. There will be a mini mock exam. We try to do it every 4 to 6 weekly, where you will be given few role play sessions and we'll be giving appropriate feedback and your result. We also take classes on communication skills and patient-oriented approach. You will get recording of every classes, and that will be given in the portal, usually next day. So if you don't, or if you can't go for live session, then you can always go to that recorded classes. Half of our students do recorded class because it's understandable that most of you are going to the hospital and doing job. So you can utilize the recordings as your time permits. And these recordings will stay in the portal for 10 months. So it's enough time for you to prepare. But all the notes and material will be given to you until you pass your exam. We also do discussion on job hunting after registration, making your CV and campaigns. There is a session coming up in March. We will give you the details where we will discuss about the pathways and everything. You can also add our classes as a CPD if you are a member of RSCGP or ACRAM, and you can claim total of 150 points. You'll be giving a course completion certificate. And most importantly, if you don't have 5 months time, you have already got placement for your exam. You can always make it as fast as you want, because we provide all our previous batch recordings to your portal if you make full payment. So if you don't make full payment, if you go for installment, you don't get our previous batch recordings. But with full payment, you will get full access from the day one. Cost is $8.99 Australian dollar. There is 2 installations, so half now and then half after 2 months available, but only if you join at the beginning of a course. Duration 5 months. Classes are 3 days a week, but sometimes it can be 4. So 3 days at the moment we are taking on Wednesday. We have changed Friday. So nowadays we are doing Friday, Sunday and Wednesday, 8:30 to 10:30 p.m. Sydney time. And all our mentors, so I will be your main mentors, but also there will be 2 more role play mentors. All of them are working in Australia, and they have passed their exam in a very brilliant way. And all of them are our students as well. So make sure that you will get some free sessions with them as well, so you will know how they do. But this is a very highly recommended course for anyone who is preparing for AMC Clinical. And we are proud to say that we have the highest number of candidates every month passing this exam. Okay, so there is no other hide and seek in here. Everything is very clear and direct. But still, if you have any questions, you can ask me. Okay, there is no problem with that. So that's all about the course. Any question, guys? And I'll just make you unmuted, so you can also unmute and ask questions if you want. Yes, so once you are part of the course, you will get every materials will be given in your portal. So in the portal, you can read the notes, you can go through the videos. So everything is portal based.
So I can't go to the previous
Now,
videos if I pay in installment?
Yes. Sorry, again, Dr. Sherry?
If I pay into 2 installments, I can't get the previous videos recording?
No. So you can only get the previous video recordings when you pay the full amount.
Okay, thank you.
Thank you. Sir, in the course role play classes, does every student get time to participate? That's a very common question every time. Yes, as I said, half of our students do not come as a live session. So let's say there is 100 students, 50 or 40 will come into the role play. Among them, 20 to 30, they never wants to do role play, even if we encourage them or motivate them and all. So there will be enough time. If you want to participate, we always you will always get the time, because most of the candidates, they are very shy and they don't want to do the role play. But if you want to, then there is enough time to participate. Okay. How you assess our reading materials? So reading materials is through the portal. So once you pay for the course, you will be given an access to the portal, and over there you will get all the materials. I am the only one who will give the cluster-wise sessions. That's right. And yes, you can get full access to all the previous videos after you make the full payment. So if you make the full payment, you will get access to everything from the day one. But if it's just half payment, there will be restrictions to our previous batch recordings and also physical examination classes. So if you want to get into the course, I would advise everyone to start the process straight away, because we have given access to people who has made payment, and we have already given like lots of videos of our previous batch. We have given notes and everything, so you can start your preparation even before starting the course. So I would say that start the process, because during the admission time there is a huge amount of candidates who want to join this course, and because it is only happening twice in a year, so there is always a huge amount of candidates who join the course at a time. So in this situation, we say that sometimes it can even take a week for you to get the access to the material. So especially during the free 2-week session, it will become more harder for us to give access to everyone at a time. But if you start the process now, it will become much smooth. Okay. It doesn't take more than a week most of the time. Yes, you will get recorded sessions. So today's video is recorded and you will get that. Live classes are ideally 2 hours to 2.5 hours. The interval between two installments is 2 months. All the course materials you will get access until you pass the exam. The video recordings are given for total 10 months. In one batch, there is no specific way I can give it to you. It totally depends, and it varies every time. But you will get enough way to participate in our role play, as I say. Live sessions are 8:30 p.m. to 10:30 p.m. Sydney time. How we make the payment? So you can either send me a message in my messenger, or you can also email us. So our email ID is this one. It's given in every post in the Facebook, so you can easily get it. So that's our email address, firstaidamc4536@outlook.com. And also you can go to our website. So this is our website. So you can also go through our website as well.
Will we have access to the ECG batch as well?
ECG, so you will get some idea about the ECG in our cardiac class. But if anyone needs like a formal ECG class, we don't do it in clinical because it's not the part of the syllabus. But if a lot of you request, we can always give the one that we take in MCQ. And all the timing that we give, it's Sydney time. Okay. So you will have to just find out your time according to the Sydney time. Yes, so it doesn't matter, Dr. Mark, as long as you are part of the course, you can access any classes. So our recordings are not just vanished after 1 or 2 days. It will stay there. And if you
So
have
can we?
got an invoice already,
Yeah.
sorry. So if you already got an invoice from us, but it's been over a month, likely chance that invoice is expired. So have a look that if the invoice is expired or not, because there is a due date given on your invoice. If the due date is over, then you'll need to ask a new payment link from us. Otherwise, that will work as long as the due date is there.
So can we get the ECG video that it was recorded previously, or it will not be there?
Yeah, that's fine. We can give it to you from the MCQ batch. It's not a problem. So we can always discuss that once the course starts. Okay, it's not a problem. But we don't take it like a separate ECG class because it's not important for clinical. But definitely, I understand from where you are coming. We will discuss the ECGs, the important ones that's coming in the exam in our cardiac class, and that's all that you actually will require. So the ECG of atrial fibrillation, SVT, MI, those come in exam. So that will be discussed by me in the free 2-week sessions.
Okay, thank you.
All right, so that's it for tonight, guys. So I hope you enjoyed our session, and I know there is still a lot of questions in your head. So feel free to ask the questions in our free 2-week sessions. And also, if there is any specific queries you have, feel free to email or send an inbox to my messenger. Okay. Thank you. And remember one thing, that the journey of AMC Clinical is not like very smooth like your AMC MCQ, but we are here to make it smooth for you. So all you need to do is to listen to what we are saying, the guidelines that we are providing that are updated, because we are working in Australia and we follow the updated guidelines. So we know what's happening in here, but most of you don't. So that's where you can get the help. And this is a very affordable course for IMJs. There are courses which are taken by doctors, but they are also like doctors, just like how we are doctors in here, but the payment can be even $10,000 to $12,000. So I don't see any difference between those courses and our courses, but still, I want you to understand. Have a look on our students who are passing the exam, because the rate of success is much higher than any highly paid courses in Australia. Okay, so there is no need of you to go and waste $10,000 for any courses that exactly is the same, or even maybe not even the same. Okay, so you can only decide after getting their feedback or even getting their free sessions. Have a look and then decide. And that's one of the reasons why we provide 2-week sessions, because anyone can take a class brilliantly. Anyone can take a very fabulous class, but no one can take 2-week sessions like very interesting if their actual classes are not interesting. So 2-week sessions are for you to understand how our classes are going to be, and then you can always decide as well. Okay. Thank you, everyone. Very nice to see all of you here. Take care, and we will start from 10th of March. Have a good night.